Hi, welcome everyone. I think we're going to go ahead and get started. Just in terms of logistics, the lunches are back here in this corner. Please feel free to walk over and get your lunch, and don't worry about interrupting us. We're quite used to that in the interesting rooms on Capitol Hill, so no worries there. Welcome. Thank you so much for joining us for this really important discussion. I'm Candace DeMatteis. I'm the Policy Director for the Partnership to Fight Chronic Disease. This is an issue near and dear to our hearts for many reasons. We love working with the Caregiver Action Network. It is National Alzheimer's Awareness Month and National Family Caregivers Month as well. So great to do service to both of those important issues. Before we get started, I did want to introduce our co-host, CEO of the Caregiver Action Network, Marvell Adams Jr. Thank you.
You have to do the clapping afterwards as a judgment, but I appreciate the preemptory. My name is Marvell Adams Jr. I serve as the CEO of Caregiver Action Network, and just really excited to be here to co-host this panel discussion. I have to say personally that Alzheimer's disease and the tragedies that it brings to families is the reason I got into the field of aging services and supporting caregivers. And so hearing that there are really now great advances in treatments that can help caregivers and their loved ones now. It's just a very encouraging time for all of us. And so during National Family Caregivers Month and Alzheimer's Awareness Month, this is just a very apropos time for us to discuss. So just a big thank you to our partners and to our panelists today for being here. Thanks so much. Candace.
Thank you. Thanks so much. I'm a little shorter than Marvell is. As we mentioned, it is an important awareness month, November, for both Alzheimer's disease and to recognize the heroic efforts of caregivers everywhere, not just for Alzheimer's disease, but any number of chronic conditions. It gives us the unique opportunity to reflect on the disease itself and the impact on families and the patients as well. And candidly, we're here to talk about how leaders in Washington can make a difference and help families dealing with these important issues. We're in a really exciting era, finally, for Alzheimer's disease. Before new treatments coming out recently that actually impact the course of illness, it had been 20 years since we'd had any new treatments for Alzheimer's disease, and those were more addressing symptoms. But we finally are seeing breakthroughs that we've been waiting for a long time, and that research and that tremendous investment is paying off. So we have FDA-approved therapies that aim to slow disease progression and address the early stages of disease. As you know, Medicare coverage has also adapted. It's expanded the availability of PET scans very recently that are needed for diagnosis and then also tracking progress of treatments. And then 5 months ago, we had an FDA traditional approval of a drug that I mentioned that affects the early stages of disease and delays progression. And they started a registry and are requiring people to get Medicare coverage to sign up for that registry. We're going to talk to several experts today, including an Alzheimer's caregiver, providers in the field working directly with patients and caregivers, and then also an expert who's done some analysis around Medicare coverage policies and how that impacts on access. There will be an opportunity for Q&A at the end as well, but I'm going to go ahead and launch us and get us started. What I plan to do is I'm just going to briefly introduce all our speakers, and then I'm going to direct a question to each of them and give them some chance to respond, and then we'll have several rounds of questions. If I don't cover your question, please feel free to ask. As I mentioned, we'll have Q&A at the end, but if there's something really pressing, you're like, oh, I really, I have a follow-up, please raise your hand. We want this to be informative for you and interactive, so feel free to interrupt me. Right beside me, I've got Victoria Liu, who's Associate Director, Reimbursement and Policy Insights at Exenda Syncora. Next to her is Dr. Sharab Sharma, who is a neurologist and at the Memory and Cognitive Disorders Neurology at Georgetown University MedStar Health. Thank you, Dr. Sharma. And then beside him is Sarah Harlock, who is the Program Director at Integrative Center for Memory at Dent Neurological Institute in Buffalo, New York. So Dr. Sharma, I am going to, I'm sorry, and Walter. Hi, Walter, can you hear us?
Yeah, sure, I can hear you, and I really apologize for coming late. I just had some inconveniences, but I made it, and I'm sorry. Hope you understand.
We understand Walter Weiss is a caregiver for his father who has Alzheimer's disease. And Walter, we so appreciate the taking time to be here, and please, no apologies necessary. Okay, so I'm going to start with you, Dr. Sharma. Can you help us understand if I'm a new patient and I've run the gauntlet, I've accepted that something's going on with me, and I call your office and I've got an appointment, what's next? What does that look like in terms of the diagnostic workup and, running through to treatment? How long does that process take, and what does it all involve?
A long time.
Oh, I'm sorry. Can you turn on your mic? Sorry.
Is that good? Is it on?
Yeah, you might just want to pull it a little closer. There you go.
Yep. It takes a long time. So the first barrier would be getting an appointment with a memory specialist. So that's for the average person that would call our office would maybe wait 3 to 6 months to even get an appointment, and that's just because of the lack of specialists who are diagnosing and treating these conditions. So usually most of this initially falls on the primary care doctor, and they do their best to diagnose and manage this. And eventually, hopefully they do get to see a specialist, and if they get to that process is delayed. So we're already several months back. And then when we finally see them, we're initiating our workup. We're taking a history. We are having to do various tests, exams, cognitive tests, images, blood tests. All of these things take time to coordinate and schedule, and then follow-up visits where we can begin to understand what's going on. So just arriving to a diagnosis for someone who's new and has never been evaluated before can take several months.
Sarah, turning to you, I know you do a similar workup. Is that pretty typical? And then what does that process look like to treatment? And I was curious because the registry for Medicare coverage opened up in July. So I was curious if you could talk about that, and then how many patients have actually made it through to the stage where they're actually receiving treatment?
So Dent Neurologic is one of the largest private outpatient practices, neurology practices. And we have not just specialized neurology clinics, but we have imaging, we have an infusion center, and we have other services as well. So we're all under one roof. And, but still, the time it takes to get a patient into the doors and the workup completed and then into the infusion chair for the treatment can take several months still. Typically, we can see patients within 3 to 4 weeks to meet with the neurologist. And then from there, though, the process does take some time. And I would also like to say, too, and to sort of echo what Candace was saying, this is a very exciting time for patients. It's a very hopeful and exciting time for patients and for professionals in this field. As Candace said, we've been waiting a very long time to be able to have these new tools in our toolbox and be able to offer more hope to the patients. I have been in this field for about 28 years across a variety of different settings, and it is, as I said, very exciting to be able to talk to people about these kinds of new treatments. So as far as the actual registry that you had mentioned, so for those of you who may not know, there is a required element in this treatment to get covered by Medicare. Patients have to be registered in this registry. And the registry itself is not particularly cumbersome. However, we are, as I said, all under one roof, and we have people within our clinics that can do this work. If somebody is in a standalone neurology practice, this might be quite a burden for them, on top of all of the other pieces that are required. So when we're thinking about, and if you have to stop me, you
No, you're
stop
fine.
me, but
Keep going.
there, to get somebody from the point of a probable Alzheimer's disease to sitting in the infusion chair to receive this treatment is many steps. And we are, as I said, all under one roof. It's a 2-page process. When I wrote it out step by step, it is a 2-page process to get that patient there. So there are many steps, and the degree of coordination between the prescribing provider, the patient, the infusion center, the imaging centers is really significant. And so people are going to have to develop new communication patterns and ways of communicating. For example, the number that comes up on the registry has to be included on the infusion billing documentation. So while it might be the prescribing provider that enters the information on the registry, they have to share that information with the infusion centers. So there is a lot of little steps and some very big steps that have to be taken.
And how many people at Dent have made it through that
Currently,
process?
we have 4. Some of these patients came to us from clinical trials, and we do have a very active research team that's been doing clinical trials. Some of our patients have actually come from Canada, where that treatment is not available. And then we do have patients working through the pipeline to receive that treatment. But it did take our first patient from the time she was given the diagnosis of probable mild cognitive impairment, probable Alzheimer's disease, to the time that she got in the infusion chair was 3 months. So it does take time.
And Walter, I'm going to turn to you. I don't know if you could hear that, but they were talking a lot about the time that it takes in terms of, getting your loved one in to be diagnosed. And I was curious, is that similar to your journey? That and what has that time meant to you in terms of getting that access and getting the treatment and knowing what's going on, candidly? Walter, I'm sorry, you might be on mute. Is he on mute?
Sorry, I didn't get your question clearly. I'm sorry. Would you repeat? And I didn't capture what you said very well. If you don't mind, you can repeat, please.
Sure. I was asking about time. We were talking about the time delays and just the number of steps that it takes to get someone diagnosed with Alzheimer's disease, and then to be able to get treatment, supports, and everything else that accompanies that. And I know time is so precious when you're caring for someone with Alzheimer's disease. And so I was curious if that is similar to what you experienced, or what did you experience with your father in terms of diagnosis and any barriers you encountered to getting diagnosis and then care for your dad.
So what I could say about that is that it was it was back in 2019. It was very hard to notice that my dad is experiencing this condition, because when it started, we thought that maybe it's something that came by the age. When when people get old, they change their behaviors, they tend to forget and everything. But now, I'd say we were able to notice, because it was weird. It was something that changed like instantly. And now because we had lived with our father for quite some time, we knew him very well. Now when those symptoms started appearing, we were able to notice. We went to the hospitals, and the doctor was able to, through some scans, through some physical examination, they were able to diagnose my father with the condition, and then he started the treatment right away. And yeah, that's all I can say. But it did not take a lot of time before he was diagnosed.
Thanks, Walter. I'm going to get to you, Victoria, but I did want to ask Dr. Sharma and Sarah one more question. we talked about the time of diagnosis, but what is actually involved? I know there was a new coverage, Medicare change in coverage around PET scans, which, as I understand, is kind of where you get an image of the brain and you can see the plaques. Is that what you're using to diagnose, or how has that coverage policy changed that? And is that making access more readily available? Dr. Sharma, do you mind starting?
Yeah, I'll start, and I'll just clarify, for the previous question, I was referring to sort of speaking on behalf of neurologists in the country and what the wait and times are and how long it can take. Similar to Dent Neurologic Institute, we kind of do everything under one roof, and we do try to get, we have many neurologists that can evaluate these patients, but in across the country, that luxury is not there, and so that's why I was referring to it can be a very long wait time. But yes, the approval of the amyloid PET scans has been an incredible achievement. Because of that, so it's alive, it's an active process. It just started a couple of weeks ago where we can start ordering these. And so, I think we're just going to start seeing the repercussions of that in the coming weeks and months. But essentially, it will dramatically reduce the time to diagnosis because we're not relying on more complicated tests, experimental, trying to get them into experimental trials to get these types of scans. We can just order an amyloid PET scan, and at least as it relates to Alzheimer's disease, we can arrive at a diagnosis, within weeks or days, depending on how quickly they can get the scan. So that is really cutting down the time, or we expect it to cut down the time.
Sarah, is that what you guys are using, the PET scans, or?
So in our area, we don't yet have information about the copays related to the amyloid PET. So because this medication or these treatments are removing amyloid, you have to make sure that amyloid is present before you start these treatments. So the way we've been doing it so far is to ask the patients to do a lumbar puncture, and we test the cerebral spinal fluid to assess for amyloid. That is a barrier for patients in some cases. They just don't want to do that. So the amyloid PET will be an opportunity, I think, for a lot more patients to participate and be able then to get treatment if they are appropriate.
Victoria, to you. The reason amyloid PET scans have not been available for Alzheimer's disease was because of a policy that Medicare had around coverage for evidence development. And I know that you've done a lot of research and are getting ready to release a study that has really looked at the CED process and what's involved and how that affects access. So I'd love to turn it over to you to talk more about that and what your study found.
Yeah, sure. So let me provide some more background and context around that coverage policy. So CMS may issue what's called a national coverage determination. And so this is where they provide a single coverage standard over an FDA-approved product or service, and that will be covered under Medicare. In 2005, CMS introduced this idea of a national coverage determination requiring coverage with evidence development, which is what we're referring to as CED here. So, there's a lot of questions around CMS's statutory authority to implement these coverage restrictions, but in 2006, they formally issued it into guidance. And initially, CMS had used the CED policy to accelerate access to medical devices and diagnostics, but recently we've seen them use it on on-label medications that have been FDA approved. So one of those CED policies covers the FDA-approved monoclonal antibodies targeting amyloid for the treatment of Alzheimer's disease. And so we've been seeing CMS use this policy to really restrict access to certain medications and FDA treatments, and we've been seeing their continued use of it. And sort of the implications of that is that there's a lot of burden placed on providers and patients because they have to help patients enroll in a clinical trial study in order to get access to these treatments. And so, as you mentioned, I recently worked on a white paper that will be published next week. And so for anyone who wants to read it, we could send it to you. But we surveyed 400 providers from a range of specialties, including oncology, radiology, neurology, and asked them about their experience with CED and their awareness of the policy. And what we found was, for a lot of the providers, there's quite a lot of administrative, financial, and operational burdens that are placed on them to make sure that they're enrolling these patients in clinical trials or enrolling in the registries to provide data to CMS in order for that product or service to graduate from the CED program. And we also interviewed some of the providers and patients to hear more about their detailed perspective on, how the CED process has burdened them. And in terms of patients, deciding whether or not to go on a treatment is already a very difficult decision, but adding kind of another layer of, you either have to be enrolled in a clinical trial study to get this treatment, or your data is going to be provided in a registry to CMS, there could be a lot of hesitancy there, and I'd love to hear from any of your experiences around this. But, patients might have hesitancy in terms of, what's going to happen with their data that's being provided to CMS. They might lack health literacy and understanding kind of the investigable nature of the CED process, and why CMS requiring further research and data collection on these products and services that have been FDA approved. And Dr. Sharma mentioned that the PET scan CED was recently removed last month, and so obviously that's a huge accomplishment and win, but it took quite a long time for us to get there. There was almost a decade of evidence generation that went into that, and 30 plus peer-reviewed journals that were produced and provided the evidence to CMS that these amyloid PET scans are valuable and that patients should receive coverage for it. But I will say the kicker of that is, CMS didn't actually provide broad national coverage to PET scans. Instead, it was deferred to local contractors. So really these policies kind of create a barrier additional to patients when they're making these treatment decisions, and also to providers as well.
So, and I think Sarah alluded to that, like you're waiting to hear what that local coverage is going to look like since there wasn't a broad coverage. I wanted to talk a little bit about cost too, because I think that's a big pushback, I think, on a lot of these new treatments. But there was a recent study published by the University of Michigan that talked about the financial fallout of dementia, and particularly on families like Walter's. They found that people's net worth declines by 60% within 8 years of a diagnosis, and their medical out-of-pocket costs double. By the end of the second year, people with dementia need 3 times more hours of care than their peers without dementia did. So again, that context is really important when you're talking about costs of Alzheimer's disease. That really falls on the families often, particularly out-of-pocket costs, or on the individual. Walter, I was curious for you how significant the decline has been with your dad, and how quick. And how has that changed your caregiving responsibilities over that time frame, from the time he was diagnosed till today? Did you hear the question, Walter? You're on mute again, sorry.
If you can maybe go closer to the mic, I'll be in a position to hear you well, please.
Sure. We were talking about the time, in a short period of time, people's caregiving needs increase a great deal. And I was curious, and the cost candidly involved that you incur. I was wondering what your experience has been with your father in terms of how, from the time he was diagnosed to where he is now, and what his needs are, and the demands on your time as well.
I'll say that the time has been very hard, and the conditions has worsened, and I would say that it has been a journey, like being there for him, making sure he's okay, dealing with his anger, mood swing, and everything. It has been really hard, and also I would say it's a mental strain, dealing with my father and seeing him with those conditions, seeing him not be in a position to do things on his own, not, and also the fact that I have disengaged my life, like, from my social life, like my friends and all that, because I have to be there for my dad. I would say it has been really a very tough time, but I'll say through the support and from my family and my friends, we have been able to move on very well, and and the medication, apart from maybe like the medication, getting the medicines, it has been really a challenge because of the prices, and also the insurance is not covering like when it comes to medicine. Also, it has been really a tough journey.
Thank you for sharing that. I wanted
Yeah.
to also ask about underserved populations. And I know you've done a lot of work, both of you talked about clinical research and clinical trials, but we know that Alzheimer's disease disproportionately affects certain communities and makes access more difficult. Yet clinical trial enrollment is lower among communities of color, for example. It's difficult for people in rural areas to participate. So I was curious about your experiences with health equity issues, clinical trial enrollment, and clinical study enrollments, and how this coverage with evidence development might factor into that. Dr. Sharma, do you want to start?
Sure.
Do you mind?
Yeah, that's a very important issue with the first new drug that's technically the second new drug, but the first that we're going to start using, the lecanemab, for that trial. There was less than 10% or so that were minority, and so of several hundred patients, you had only like 20 that were African American. So you can't really extrapolate a lot regarding how the drug works in that subgroup, because the majority of the patients in the study were not were Caucasian, and we know, for example, individuals in the African American community they tend to have less amyloid and tau in the brain, and even though that doesn't correlate necessarily with the dementia or the symptoms, but because they have less amyloid and tau in the brain, when we try to recruit them and look for, when they get these experimental scans, they may be excluded from the trials simply because they don't have enough amyloid, even though they may be really at the most risk. So that's been part of the challenge, is sort of the biology of it, but also just being able to give these other groups access to clinical trials, and to educate the communities on clinical trials. And so we try to do the outreach that we can for that.
Is there still a lot of distrust in terms of being part of a clinical study?
Yeah, and that distrust is always there. I think I think that can happen with any community. But yes, I mean, that's part of it. I don't think that's the primary issue. I think it's more the availability of resources, and the people enrolled in clinical trials tend to be more affluent and tend to be closer to these centers where these things are offered.
And Sarah, you mentioned that sometimes when you're counseling people, the idea that they're going to be part of a registry may be a deterrent. Can you speak to that a little bit about some of the conversations you've had to have?
To date, no, people have not actually refused to continue on the process because of that registry, but it does make them stop and ask the questions. What is happening with my data? And certainly that education piece about clinical trials is critical. A lot of people feel that they don't necessarily understand the difference between phase 1, phase 2, and phase 3, and so they think that all clinical trials are high risk and brand new and so on, and they don't realize that maybe a phase 3 already has safety data and attributed to it and so on. And so there is just a great deal of education, and to Dr. Sharma's point, that need to be able to get transportation to the center that's offering the clinical trial is really important. And very often these clinical trials require you to have a care partner with you, so that we can get information from both the patient and the care partner as far as changes.
Victoria, you mentioned that, I know in CMS, in making this coverage with evidence development requirement, said they are open to opening coverage with more evidence. I mean, that's the whole point of CED. How long does that take? You mentioned the PET scan was about 10 years.
So straightforward, only 7 have been removed. And so 5 were retired because there was enough evidence collected that fulfilled the CED requirements. So CMS retired those, and the time frame for that ranged from 4 to 12 years, so quite a long time. And 2 CED policies were revoked, and coverage was deferred to local contractors, and those decisions took between 10 to 13 years. For the remaining 20, it's really unknown. There's not a lot of guidance from CMS on the status of data collection and how far along data collection has become to fulfill the CD requirements. And so it really is kind of almost a black hole for a lot of these products and services, not really knowing when full access is going to be granted to these treatments for Medicare beneficiaries.
And have you seen, did you study, I'm sorry, was there a question? Yeah, no, go ahead.
I just want to know, do you know what the access of those products that were sent down to the regional level for approval? Do you know how often that's been approved or denied? Does that make sense?
Yeah, that level of detail I do not know. I think it'll depend kind of locally on that determination, yeah.
We did a little bit, PFCD did a little research on local coverage determinations, and it really can vary. They're very, just in terms of, for example, the PET scans for oncology. A lot of them were very similar, but then some of them would have a difference, for example, whether a genetic blood test would qualify someone for coverage, and that varied from region to region. So you really can have someone in Wisconsin with a different coverage opportunity than someone in Texas because of those regional differences. Any other questions? I'm happy to open it up. I've got several, but I'd love to open it up to the audience. Yes, in the back row.
Yeah, I can answer that one.
Sure.
Definitely a problem that is of concern in that they're going to apply it to other therapeutic areas as well, and potentially block access to whole classes of therapeutic agents. I think really kind of the latest CED that affects those on-label medications is concerning because CMS, in a way, is kind of undermining the FDA approval process when they implemented that policy. In terms of reasoning, there could be a whole host of reasons from CMS, but they felt that they needed to collect more research and collect more data in order to really deem those products reasonable and necessary to provide to Medicare beneficiaries. But that definitely is a rising concern.
And how is that? I'm interested from our providers. How is that? I think that's relatively new to neurology. Now, I don't know you may know all the CEDs, but I'm curious. Have you gotten the guidance that you need from CMS in terms of figuring out, Sarah, you mentioned not knowing about PET scans, like how much is the individual going to have to pay? And, if I'm a patient coming in or a caregiver, and especially someone on a fixed income, that's information I want to know. Do you have that information that you need, or is more guidance needed to be able to facilitate that access?
At this point, we don't have the information from our local MAC about what the co-pays will be. We are anticipating that decision shortly. As far as the registry goes, it is not difficult questions to answer. It could be burdensome, as we've talked, to some providers. But I also wonder if the information that CMS is truly seeking will actually be answered by those questions, because the registry has opportunities for you to, or you're required, to put in cognitive assessment scores and functional assessment scores, but you're not required to use the same tools. And so if some tools are more sensitive to change than others, are we able to really compare the data, and will we get the information that we need in order for CMS to make decisions?
Is that your experience too, Dr.
Yeah,
Sherman?
I agree. I agree with that. Yeah.
And Victoria, is that, I don't know if in your research you looked at the registries. This is a little novel too, is my understanding that CMS actually set up a portal versus having the registry be with someone. Like you talked about, you had done with cardiovascular, I know there's a big TAVR registry, and that's handled by the medical societies. So is that a little different? And to Sarah's point, is it asking the questions that they're going to need?
Yeah, it is a little bit different. I think it's CMS's way of perhaps trying to make it more easier to provide that data. But the portal is so new, we kind of don't really know whether or not it actually is making the lives of providers easier. But we have seen that, just setting up the registries can take quite a long time, ranging from like 18 to 24 months. And, at that time, patient access is being delayed and delayed initiation of patient treatment.
Did we lose Walter? I had a question for him. Walter, are you still there? Okay, if not, one question I wanted to pose to all of you before we open it up for more audience questions is, given the importance of this illness, and it is, not just something that we recognize this month, but, throughout the year, and people like Walter who are living with it day to day, get no break from thinking about it. But what could Congress do to really help in terms of facilitating support for caregivers, giving people more access to, diagnosis and treatment and the like? Do you have some thoughts there? Victoria, do you want to start?
Sure,
We'll
I can
walk
start.
down the line.
I think definitely what Congress can do is kind of examine the CED policy and really examine what's its intent. Is it helping patients get more efficient access to these treatments, or is it instead providing more burden and an additional barrier to patients to get their treatment? Should they continue to use CED policy and apply it to more FDA-approved products and services? As Sarah mentioned, provide more guidance on that. What does it actually take for these products and services to graduate from that program? How long will data collection be needed? And at what point is enough data sufficient for CED to be removed from these products and services? Also, I think, engaging more patients, because, at the end of the day, it's the patients who should be at the center of these policies. So, CMS does provide, open comment period opportunities when they do put out these guidances. So really encouraging patients to become involved in that process so that their voices and their needs are heard as CMS is creating these policies.
Thank you. Dr. Sharma, any thoughts there?
A couple of things I would say. First, incentivizing clinicians to provide this care. I think that's been one of the biggest challenges is that practitioners don't necessarily want to engage in the lengthy process of evaluating, diagnosing, treating these patients, because traditionally reimbursement for that time has not been good compared to other challenges. Now that's changed recently. In the last couple of years, we do have opportunities to for providers who provide this comprehensive care. There are new codes and all through Medicare, which I think has helped. So supporting those kinds of initiatives. I think also, we didn't talk too much about the guide model, but that is a new initiative, and although I don't think that's through Congress, but supporting initiatives like that. So the guide model will help centers, hospital centers, and other centers that will commit to having the resources to help patients with dementia and family members, to have coordinators and assistants 24/7, all of these kinds of things that with the guide model that will be reimbursed to the institution, that those kinds of things will really help move this along.
Thank you. Sarah?
I had two thoughts about that. One is we need to be supporting primary care with appropriate tools that fit into a primary care workflow to be able to detect cognitive impairment at a much earlier stage than we are currently. And so we need to be supporting primary care in that way. And the other is to be looking at infusion centers. So these medications and treatments are infusion only at this point. And so NICA, the National Infusion Centers Association, has an infusion center locator that you can look up and find infusion centers near you. But we need to be thinking about access to those. If patients are 3 hours away from the nearest infusion center, what's our transportation situation like? Is there a way to offer group transportation or things like that that will allow patients to receive these treatments? The medication that's currently covered by CMS has a cadence of every 2 weeks. that's a lot to ask, you know, an adult child to take time off of work every 2 weeks to take somebody to an infusion. So we really need to be looking at transportation and so on to the infusion centers and having access to them.
Thank you. Walter, I want to turn to you now. You've got an audience of people who have influence over people who have a lot of influence. What would you like to see change for caregivers? What kinds of supports do caregivers need? You're on mute again.
I don't know why I'm forgetting to unmute myself. So I was saying that what I would really like maybe to be changed is that maybe there should be like educational institutions where caregivers should be be trained, because if you lack this training, like for instance, you know, when like for myself, it was very hard, like dealing with the stress, especially the memory loss, you know, reminding my dad each and every time. So it was a very, I almost fall into depression and all that. So I think the support that I would really appreciate is the educative support, like where the caregiver should be educated on how to, you know, how to control the, how they think, maybe how to control the, you know, their way of thinking. That's the only thing. That's the only thing I think should be done, and also people should, people should be informed of caregiving. It's not something simple. People should, be informed on that. But now the main thing I would ask is caregivers should be trained. Like there should be that training.
No, that's a great point. I think when you
Yeah.
think about you're handling financial, you're handling medicines, you're coordinating care and doctor's appointment, all the while watching a loved one change. And there are mood swings and all kinds of different issues that involve. So thank you for that. I did want to mention the guide model that Dr. Sharma mentioned as well is a new program within the Centers for Medicare and Medicaid Innovation. And it's a new demonstration that really helps to alleviate, designed to help to alleviate some of that burden on the caregivers by taking some of that coordination responsibility and reimbursing providers to help center the care on the patient, support the caregiver, take some of that navigation and responsibilities off of caregivers, and also provide that stress relief and other supports. So a really important model that was great. Questions from the audience? Jay?
I was really happy to hear you mention the role that primary care can play in this, and particularly with early detection. And I know that can be tricky sometimes. You know, I have a relative that went through this recently about, the role of the caregiver and how the caregiver can interact with primary care, and how can this team sort of really help with primary care to not only make sure that the diagnosis is being talked about, but to make sure that the patient actually maybe is even going to see treatment. So I'd just love your thoughts about how that all can work together. We're excited about the guide model, and I think that's really aimed at that idea. But a lot of times with the early onset, people aren't in Medicare yet. So just any
Right.
thoughts, comments?
Right. So we certainly work with primary very closely. I often talk to caregivers about, your primary care is your quarterback. And, well, we're from Buffalo, right? So we're a big football town. So your primary is your quarterback, and, and then your other specialists are your other teammates. And as a patient and a care partner, you're a part of that team. It is really important that we are thinking about that early detection piece. And I think there are tools out there that primary care can utilize. There are a lot of digital cognitive assessment tools that can detect mild cognitive impairment and so on out there. Now they're starting to be reimbursed, and there's an opportunity to use those. And as Dr. Sharma said, there are some newer codes, they've been around a little while now, that primary providers can use as well to sort of do that sort of care planning piece. I do think that the guide model will be incredibly helpful. And to speak to your early onset comment, it is true that a lot of the patients with what we call young onset, so under the age of 65, who are starting to show signs of cognitive impairment, may not be having conversations. I think that it's critically important that we are starting to normalize conversations about cognition. That if somebody is in their 30s and 40s, we can ask about anxiety or depression, because that can affect cognition, memory, and so on. And when a woman is in her 40s, we could be talking about perimenopause, because that too can be affecting memory and cognition and sleep and so on. So I think the more we start talking about cognition and normalizing that conversation, the more willing people will be, or the more aware people will be to say, yeah, I am having these changes, or my family member's saying I'm, having these changes. So I think normalizing the conversation about cognition is critically important in this.
And I just wanted to add on that point you mentioned about the early onset, and it's like the magic numbers, you have to be 65 in order to start getting covered for these things, and it's just not what we see in practice. There's people develop pre-dementia many years before often, and actually early onset is increasing. So having to tell someone, I'm sorry, I can't do this or order this test, you have to wait till you're 65 is incredibly frustrating. So that needs to change.
Yeah, that's a great point. I saw, and I'm going to get to your question next, I read that there are many, because of the CED policy that Medicare put in place, it's very unusual for a health plan to just say, we're not going to cover X drug or X procedure. But with a CED policy in place, that actually is more common, because they say then it's experimental and point to the fact that Medicare is not covering it absent participation in a clinical study. So that's affecting the availability of younger people. When you want to, every other disease, you want to catch it early, just like a cancer. You want to catch it early and treat it aggressively and give people the most quality of life and long life that you can. But because of this policy, we're seeing health plans, private plans announce, oh, we're not covering it because it's experimental, because CMS is requiring CED. So that really hurts people when you can get them, earlier stages, but are younger. Question?
And take one altogether? Well, I can start. I would say, yes, having that conversation is probably the norm, is the norm. Because again, when patients come to you, I would say the majority of them are ineligible because of their level of impairment is moderate. It's not mild. So, and that goes back to how we need to get more of the earlies and pre's into our clinic sooner. So that's actually quite common, having to have those conversations. It's difficult, but I explained that the new treatments are a wonderful breakthrough, but they're still not the be-all, and there's a lot more to be done. And this is just the beginning treatment. And try to tell them that there's traditional care we can still offer them. The blood test, kind of a double-edged sword. I think finding the right one. There's different labs doing different tests right now, so we need some consistency as to which ones we're using. And having a positive blood test showing amyloid doesn't often or always mean that you either have dementia or will get it. So Quest giving this access to patients that can just get it online in some ways, yes, it can be helpful because they come in earlier, but in other ways, it can be anxiety-provoking, and it needs to be delivered in the right context. And so we really need, I think we need to identify the best blood tests, and eventually they should become part of a screening process through primary care. And that could lead to referrals. So that is probably the future.
Perfectly said.
I was curious about that too with the, sometimes people have, one of the criticisms I've heard is, well, it delays it by, several months. And I know that total is continuing as the clinical trial extends out in terms of delaying progression. But you see it, because we haven't had these treatments for Alzheimer's disease, but you see it in cancer, is that people want that delay. I mean, any delay is precious, right, to maintain independence and everything else. But it also, with the research pipeline and the breakthroughs that are happening, it gives people hope for, okay, this will buy me another 6, 8, 12 months. But maybe by then there'll be something more, and I'll, it'll cure me, or it'll, prevent it longer than that. Are you having those conversations at all, or is it still too early to be thinking that way?
I think it's a little early I'm not a provider though, so I would defer to Dr. Sharma on that, but I think it's maybe a little early. I typically don't talk about those sorts of things until it's real, and we can offer it to patients and family members.
Good point.
Yeah, I mean, I think you always want to give hope where you can, and so telling, well, with the 2-week infusions, which is burdensome, there's early data showing that the treatment can be given as an injection, and so that will be hopefully coming out in the next several months, and so that can I've had some conversations that I'm trying to tell some patients, if it's something we can hopefully transition you to an injection that you do at home, that will be huge, and the next big potential treatment, donanemab, is once a month, and so that telling again patients, well, maybe we can make it this once a month if we find that drug may be better. So yes, we do try to give them hope where we can.
Great. Any other questions? Yeah.
Oh,
Sorry. Marvell, do you want to go, or?
No, I was just going to, estimates say that by the end of this decade, up to 40% of individuals living with Alzheimer's disease will have color. And how do you envision, or would you want efforts to be made to close the gap when it comes to clinical trials and reaching out to marginalized groups?
Any suggestions here?
Well, so one of with the amyloid PET scans, for example, been several years in the making, but with the IDEAS study, which is still ongoing, they essentially are redoing the entire trial for amyloid PET scans, but only seeking, making each site do, first enroll like 10 people from the African American community first before you can enroll anyone else. So and so that it's going to have to be those kinds of initiatives, and other trials are doing that too, where for every one Caucasian individual you have to have, for every Caucasian individual you must enroll a non-Caucasian individual as well before you can do the next one. So I think strategies like that can be helpful, and then again, education and reaching out to communities of color and building that trust. So those are important.
Thank you. Did you have a question?
yes. So earlier, my question was because I enjoy data. But I also serve as the director of advocacy policy for the National Down Syndrome Society. And for individuals with Down syndrome, the risk of developing Alzheimer's increases with each decade of life, starting at age 40. And the overall lifetime risk of developing Alzheimer's is more than 90%. From your perspective, what can we be doing to ensure Down syndrome is part of and being considered for your research, for the therapies that are being developed, as well as the care processes that you all are looking into?
Sarah, do you want to start with that one?
I'm not sure what our research team is doing around including patients with Down syndrome. I know that we do certainly see patients in the clinic regularly. We have tools that are specifically designated as far as trying to detect dementia in that population and in those individuals. And so I think part of it is the research, but I'm not aware of Downs as certainly not an exclusion criteria
Right.
in the clinical trials.
I think that it's a great question. I think that the reason, it's not that they're excluded, but to be included, you have to be able to participate in cognitive testing. And I think that's, yeah, and you have to have cutoff scores before you can get in. And I think that's probably why most of them would be excluded, because by the time they're showing symptoms, you can't, they don't meet the inclusion criteria because they're testing too low. I think that's probably the biggest reason, and also just they're not as aware about clinical trials, the people who are caring for them. Many times, they're in nursing home type settings, and so they may not be aware of clinical trials to begin with.
Any other questions from our audience? Marvell, would you like to say a few words before we conclude?
Just a big thank you to the panel. This gives us even more reason for optimism, but also gives us a challenge for the things that we really need to do in order to make further strides in Alzheimer's treatments. For me personally, it is a great honor to be here today because there is so much good work to be done, but also recognizing that Alzheimer's disease does not have a filter for race or identity, but we do recognize that there are aspects of identity that have to be addressed when it comes to clinical trials, so thanks so much for your feedback on it. Thanks, Candace, for organizing. I really appreciate all the time and the effort you put into it. And I will go as far as say, as most importantly, Walter, thank you so much for being here today. It really is amazing to see the time and effort and patience that you must have with your dad, and all of us are rooting for clinical trials and efforts in Alzheimer's treatments to make big jumps in the future. So thanks so much, Walter.
Thank you. Thank you all.
Thanks for coming.
You're welcome.